Good morning. Thank you very much for joining us this morning. I love the energy in the room. I sense a passion both for connection and also connection with this subject, which today is supporting parishioners in critical healthcare decisions. I'm Paul Louis Metzger, the director of the Institute for Cultural Engagement, New Wine, New Wineskins at Multnomah University and Seminary. In a few minutes, I'm going to ask Dr. Derek Chin, the dean of the seminary, to come up and provide an opening prayer. Again, I want to thank you for coming to this event, for being here this morning, and just very grateful to Reverend Dr. Robert Macauley, who is the Cambia Health Foundation Endowed Chair in Pediatric Palliative Care, School of Medicine, Oregon Health and Science University. And I had the privilege of meeting with Dr. Macauley, with Bob, sometime this last year. Our president, Craig Williford, Dr. Williford, knows Dr. Macauley and introduced us, and just really enjoyed interacting with him. One, he has a passion for medicine, and also he has a passion for ministry for the parish. As I had said in promotional literature, he's an ordained priest, he's an Episcopalian priest, and so I just love that kind of merging and synthesis that he'll be providing for pastors, for chaplains, for other ministry leaders today. So the format, and then I'm going to ask Dr. Chin to come up and speak for a few minutes, is that we'll hear from Dr. Macauley for about 35 minutes, and then we're going to have panelists whom I'll introduce a little bit later. They'll come up and reflect for about 5 minutes each together, and then we're going to take questions from all of you. And so my colleague Sarah Mannon and I, she will help me get on your pieces of paper at the table and their pens, those questions that you might have. We'll synthesize them. I'll draw from them for Dr. Macauley and our panelists. I also want to thank Gateway Church for serving as a sponsor for this event. Really grateful, and for Multnomah Seminary for this partnership. The dean hasn't kicked me out yet, so I'm still grateful for him. And without further ado, Holy Reverend Derek Chin, if you wouldn't mind opening us in prayer.
Thanks, Paul. Actually, the only reason why we haven't gotten rid of Paul is because he works here for free. So, it's sort of a nice deal. He wants to be here for some reason. Again, my name's Derek Chin, and I want to welcome you on behalf of Multnomah University. We're very glad that you're here. And we're excited as a seminary and university to be able to serve the pastoral ministry community, ministry leaders, to talk about issues that we recognize people are facing, not just pastors and ministry leaders, but also our congregants. And then how do we effectively serve them and minister to them and train them in areas that sometimes people don't even talk about. And so I'm really excited that you're here. Appreciate that Dr. Metzger has put all of this together with his team. I appreciate what he does through New Wine, New Wineskins, because he's always thinking about how do we as Christians engage in areas that perhaps the church isn't thinking about, and brings a lens of Christ to it, and then shares that with our community, our students, the local community at large, our university. So I really appreciate what Paul does. I also want to, again, thank you for being here. We're going to be on our best behavior because my boss, Aline back there, is keeping an eye on us, but also encouraging us. He's passionate about what we are doing as an institution, and is doing some neat stuff with online education that we hope we'll be able to share with you very soon. Let me pray for our time. Lord God, we give thanks. Thank you for what it is that you're doing here through us, through the respective ministries you've called us into, whether it's church ministry, care of people, higher education. There are many things that are represented here by your people. And I pray, Father, for the conversation we get to have this morning, for the encouragement we'll receive, for lessons to be learned, insights to be shared. We pray, Father, that this would be honoring to you, that you would certainly give us ears to hear and eyes to see what it is that's going on in the world around us that perhaps we're missing, that we can actively engage and do a better job at. We thank you, Lord, for our panelists and our speaker, for how you gifted and wired them, for the gift they are giving to us this morning, to be able to, expand and represent your kingdom well. In Christ's name, amen.
Reverend Dr. Macauley.
Good morning, everybody. It's really nice to be with you all this morning. So appreciate the warm welcome and the chance to have a conversation about something that I think is really important and an area that I think that churches can really support parishioners in. At the same time, in my experience, a lot of pastors don't have as much training or education or experience in this area, so hopefully we can address that this morning. Okay, so I'd like you to imagine a situation where a parishioner comes to you and says, I'm taking a brave step. I'm kind of looking ahead to see what might happen in my life. I'm realizing that I'm a mortal being and that I will die someday, and I'm working through this statement. So this is part of the Oregon Advance Directive, and it says that you can initial the statement below if you agree with it, and says, I don't want my life prolonged by life support. I also don't want feeding tube as life support at end of life. I want my health care provider to allow me to die naturally. You can read the rest of it for yourself. And it says to you, Pastor, what do you think about this? So, show of hands, has this ever happened to you? Like, has anyone ever come to you and said, hey, I need help with this? So, quite a few folks are raising their hands. So, let's take just a couple of minutes. How have you responded? Like, what is hard about that? What is easy about that? And how well prepared do you feel in dealing with that? So, who'd like to share about their experiences?
I'll share.
Yes, ma'am.
I'm going to share from the perspective of someone that had done this, and then when the situation arose. And I think I had the privilege of being there in the hospital when the situation actually arose and knowing what their healthcare directive said. And to be able to say, because all of a sudden it starts, it's black and white when you're doing it as a form. Mm-hmm. But all of a sudden you're there and it starts looking kind of gray, And so it happened to be my dad. And so I said to my dad, okay, I know this is what you've said in your advance directive. You don't want, they were going to give him a feeding tube. And I said, you don't want feeding tubes as your life. However, if it's a bridge to getting better, that's okay, right? And he said, yes, that's right. So then as the week went on, I had a second opportunity because he was getting worse. As the week went on, I had a second opportunity to say, okay, Dad, you said in your advance directive, I went through the same thing again. And I said, and he said, yes, that's right. And then it wasn't but a day later that the situation was going to be a feeding tube for the rest of his life. He was never going to be able to swallow or eat or anything like that. So I felt privileged to be able to go through it again because it was gray once he got there. And I thought to myself, not everybody has that opportunity. Mm-hmm. So I felt pretty privileged in that case.
So thank you for sharing that. I think that is a great way of illustrating how filling out an advance directive is a way of kind of caring about the people in your life and equipping them to make decisions and help you make decisions rather than leaving them to have to fend for themselves and say, what would he want when he has never taken the opportunity to speak with me about it? Thank you for that. Yes, sir.
I want to go even farther back at the beginning when these are filled out. When we filled out ours, we were told to fill it out a certain way. When we had our advance directives reviewed by another lawyer, he said, you have filled this out backwards. So it's important when this is filled out in the first place that you get good advice about how to do this, because you can do this in a way that completely turns it around against what you really want to do. So it's really important.
So thank you for that. We'll talk a little bit more about how to fill these out and what that means. And with all due respect, I realize we have an attorney colleague who's going to be on the panel in a sec. I think these are medical forms, and I think that you need medical perspective in order to fill out these forms, because sometimes, as we'll see, people have misperceptions about what actually works and what doesn't and what the burden is associated. So there's a legal aspect, but I think there's a very profound clinical aspect. What about from a parishioner standpoint? Like if you have someone in your parish, in your church, come to you and say, hey, would you help me with this? Is this okay from a spiritual perspective? Not I'm telling you what I want, but is this okay to say, to check this box? Is it okay to say, I don't want everything? Does that ever happen? Is this something that we have conversations about? Not seeing too many nods on that one. So let's talk a little bit about what that means as we go forward. Okay, so that's part of the Oregon Advanced Directive Form. There's also, it gets even harder after that one. So same kind of questions about tube feeding, life support, but what if I'm permanently unconscious? What if I have advanced progressive illness? What if I have extraordinary suffering? This is straight out of the form. So if somebody comes and says, hey, I don't know how to do this, what, not just from a clinical standpoint, but from a spiritual standpoint, what is it okay for a Christian to say and not say? And what does Scripture and my faith lead me to do? These are really profound and complex questions. All right, so what I'd like to do this morning is I'm going to review a little bit of biblical teaching, which is not going to be a surprise to anyone here. And we're going to look at why devout patients might make the choices that they do and identify ways that we can support parishioners in making these decisions from a spiritual perspective. All right, basic stuff, verses that are familiar to everyone in the room about who we are and what we are on earth and what we are in eternity. And the contrast between those two things, because we have an eternal house in heaven as opposed to what we have here on earth. And so we look forward to eternal life. And when we look towards eternal life, we look at it in context, right? So our earthly life is a infinitesimally, literally small fraction of our eternal existence. And so one might therefore prioritize in certain ways. So logically, we should be looking forward to heaven, right? Like Christians, is that a safe statement that Christians should be looking forward to heaven one day in eternity with God? So we might be so excited about this that we just can't wait. And as a result of that, we might have certain views of our current life. We might be tempted to take a few chances in this life because maybe that means that we get to start that eternity in heaven a little faster. So we might do some fun things that have some risk. We might have some things that we really don't want to do, no matter, and that might be risky, but we're not willing to do that. But we'd at least be watching for what comes next, right? And especially when life changes for us, when we have physical illness, we have significant challenges. So what if that exit ramp to our next chapter of our life was really kind of right in front of us? Do we choose to take it, or do we choose to hold on to this life? I would argue, or I would imagine, that we would be eager to walk through the pearly gates, so to speak. That if we are suffering, if we are nearing the end of our life, we might say to ourselves, hey, this has been great. I've done my thing. I've been a faithful servant of the Lord. Now it's time to move on to the next chapter. So my argument is that if eternal bliss awaits, faithful Christians should look forward to heaven, and when it becomes clear that we are on the precipice, we would be willing to say, okay, let's move on to that and not go through extraordinary burden in this life. That would be my hypothesis, especially since studies have shown that faith impacts medical decisions. So these are studies, these are references, I've got the last slide, that most people say that their religious beliefs impact how they make decisions. And patients will say, after their physicians, oftentimes it's their faith community that is the most impactful element of how they decide what to do from a healthcare perspective. And patients prioritize spirituality. This is from a big study in the Veterans Affairs, Veterans Administration literature, where they asked a bunch of veterans, what's most important for you? And they also asked bereaved family members, and they asked physicians. And as you can see, being at peace with God for patients was the second most important thing that they identified after freedom from pain in terms of their end-of-life care. So patients are saying, hey, this is important for me to be at peace with God, to have my faith be respected. Spiritual support, QOL's quality of life. Spiritual support also impacts quality of life. So this was, the Balbonis are an interesting couple. He is a pastor in Boston. She is a radiation oncologist. They've written a really wonderful book, most recently bringing all their research on spirituality together. And what they found was that spiritual support and p-values, which we'll talk about for those of you who aren't into the statistics, a p-value is the chance that what you're seeing is based on chance, and anything less than 0.05 says it's unlikely to be based on chance. There's really a correlation. So 0.01 is significant, and it says spiritual support impacts quality of life. If someone feels spiritually supported, their quality of life is better. I don't think that that really would come as a surprise to folks here. So, if eternal bliss awaits us in heaven, we look forward to it, and faith impacts medical decision-making, I would think that if you're a devout religious person and you have sought divine guidance, asked forgiveness, trusted God to take care of you, and you accept the fact that you're terminally ill, that you'd probably opt for a treatment plan that focuses more on comfort than on prolongation of life. That would be my logical reasoning, and I would be wrong. Is that a surprise that I'm wrong? No? Do you see that? Okay, so let's look at some of the data, which clearly you guys are already seeing in your work. So this was a big study, and the Balbonis were part of this, that came out in the Journal of the American Medical Association now about 10 years ago. And it talked about religious coping and the use of life-prolonging treatment. And the conclusion of the study was that positive religious coping, I'll explain what that is in a sec, in patients with advanced cancer is associated with receipt of intensive life-prolonging medical care near death. So the more positive religious coping you were engaged in, the more aggressive the treatment was at the end of life, as opposed to focusing more on comfort. So they used a scale called the R-COPE, and it's a 14-point scale. They have positive religious coping and they have negative religious coping, which I don't think will be a surprise that people cope positively and negatively in terms of religion. So the positive religious coping is looking for a stronger connection with God, seeking God's love and care, seeking help from God, trusting in God, trying to see how God might be choosing to strengthen me, asking forgiveness. Negative religious coping would be, from a religious perspective, having negative feelings that are projected onto God, like why is God not taking care of me? Why are my prayers not being answered? So one might reasonably infer that if someone has negative religious coping, maybe they are holding on longer because they feel like they have not made peace with God and they have things that are left unresolved. That's not what we're talking about. We're talking about positive religious coping. And what this study found was that for positive religious coping and getting so-called heroic measures, that might be intensive care, intubation, CPR if your heart stops, they found that for those who did a lot of positive religious coping, trusting in God, having faith in God, asking forgiveness, they were much more likely to get all these heroic measures than people who didn't really do a whole lot of positive religious coping. So the faithful were actually asking for more aggressive care. And just to give you a sense, there are different ways of running statistics, but the odds ratio here is about 6.6, which means that the odds of someone with high religious coping asking for all this stuff is about 6 times higher than someone who's not doing a whole lot of positive religious coping. And the end result is they get a lot more intensive treatment and they get a lot more intensive care. Lest you think this is some weird study and an isolated finding, these are a bunch of other studies that found exactly the same thing. And when I just asked you guys, does that come as a surprise to you? A bunch of folks were like, no, that doesn't come as a surprise to me. So this is not some, isolated finding. This is something that seems to be out there, that is documented, and that some folks at least here have experience with. So, devout terminally ill patients are more likely to request aggressive treatment in an attempt to prolong life. That takes me by surprise. And so it makes me wonder why. And why is this important? I would argue that it's important because a lot of people suffer at the end of their lives. One of the reasons that there is a field like palliative care, which is what I do, is that there have been study after study, big studies about patients in the hospital across the country that show that a lot of patients near the end of their lives have untreated pain, they feel abandoned, they're alone, and they go through a lot of stuff that is very burdensome that doesn't end up helping them in terms of living longer or living better. Aggressive end-of-life cancer care is associated with poor quality death and also a hard time for the people who cared about those folks. Like if you just, very basically, if someone you love died peacefully with their wishes respected, as you sort of described with your dad, that's one thing. If you think back to someone you love and they were in an ICU with all kinds of tubes and things like that and had all things done to them and then they died there despite all that stuff, that's a hard thing to cope with later on in terms of your own process and your own healing. So I wonder about why is this? And so what I'd like to do is kind of explore what some of the studies have shown, and then we can have some opportunity for conversation about whether this resonates with you guys. So this is from the Balbonis book that just came out this year. And what they found was that when they asked religious coping people, why is it that you made the decisions that you made, they came up with 4 different areas. One is the notion of divine sovereignty, which is basically, it's up to God. It's not up to me. And we're going to talk more about what that means and how we can apply that. Another is miracles. Like, I'm going to hold on in the hope that, my prayers will be answered, and maybe, the doctors are speaking scientifically. I also live in a spiritual dimension, and maybe God will intervene in my situation. The sacredness of life, that this is a sacred gift that I need to cherish and honor. And some would say that suffering is God's test. And so we can, if we want, talk about what Scripture says in Jesus' life and what suffering means and what that means for us. So it comes down to the bottom line for me is, what should we do? And we as faithful Christians, you as pastors in the community. And one option I would wonder about is maybe we should provide more spiritual care to folks. That's the reason I asked you that question at the beginning. Maybe we should engage with people about medical decisions on a spiritual level in order to give them guidance about what God calls them to do and what God doesn't call them to do. The interesting piece about it is that spiritual care has different effects on patient decision-making depending on who's providing the spiritual care. So people who are well supported by their own religious community, their home parish, their home church, were actually way more likely to receive aggressive measures in the last week of life, way more likely to die in the ICU than if they received spiritual care from people within the medical establishment. And by that I mean like hospital chaplains. So if you say patients need spiritual care, especially at the end of life, I think we would all agree with that. That's an incredibly difficult chapter of life to go through. Depending on who provides that spiritual care, that tilts patients, tips them one way or the other. And it's even bigger impact for high religious copers. So people who really are saying, my religious beliefs frame my way of looking at the world and the decisions, if they say that and they get support from their own home parish or home church, they're 11 times more likely to receive aggressive measures in the last week of life and 22 times more likely to die in the ICU. So it's one thing if you sort of have a tangential relationship to your home church, you get tipped a little bit. If you really are saying, hey, my faith is important to me, my faith community is important to me, you're way more likely to go through all this at the end of life. And so this is just graphs to show this. So the light color is low spiritual support from the religious community, and the dark is high religious support. And so as you can see here, from people with high religious coping, they get way more aggressive medical care and way more high probability of dying in the ICU. So why is that? And there are a couple of reasons that are hypotheses that have been put forth. One is that clergy who work outside of a medical context may be likely to overestimate the capacity for cure. And so I don't mean to say like this is just clergy, but generally speaking, people who work outside of the medical world have a very high estimate of what medicine can do. And like medicine, we can do crazy stuff, like there are diseases that 10 years ago were incurable and now lots of people get cured. There's new treatments for cancer that are just turning cancer on its ear, and that's all awesome. At the same time, there are limits. And some of the stuff we do doesn't really look in real life the way that a lot of people think it does. Like a classic example that I talk about with medical students is CPR. And most people who don't go to medical school, they know about CPR usually because they see it on TV, right? Like unless you're an EMT or you've taken CPR courses or things like that, a lot of people understand it through television. And on television, the probability of a good outcome is hugely elevated. To the point where, and I'm going to reveal myself to be dealing with a little bit of envy in this comment. There were three physicians who about 15 years ago spent some time watching a whole season's worth of 3 medical dramas on television. And what they did is they calculated how often people got better after CPR on television, and they wrote it up and they got it published in the New England Journal of Medicine. And I'm like, I was watching those TV shows, but I just wasn't taking notes, and they got published in the New England Journal of Medicine. And what they found was that on television, people, number one, who undergo CPR tend to be young, and so if they recover, they have a nice long life ahead of them. Secondly, their hearts are fine. They got some other reason why their heart stopped, but if you get it going again, then intrinsically their heart's fine, whereas in real life that's not the case. Most people who their heart stops, they got a bad heart. And the third thing is, on TV, about 2/3 of people survive, go home, and are just like they were before. Like they actually finish CPR and wake like refreshed and rejuvenated somehow. And they do that within a 60-minute, 1 hour episode on television. And in real life, it's way different than that. So it makes sense to me why somebody who thinks that CPR would say, well, why not try? For people like me who see it every day, and especially with people who are sick enough that their heart's going to stop in a hospital, it's a much different story. So they did some studies. This was a study that came out a couple of years ago and out of Boston, where they asked clergy, not hospital chaplains, but parish clergy, they asked them some questions about medicine. And what they found was, when they asked them things like hospice care, it does focus on the comfort of patients who have 6 months or less, about 3/4 answered that correctly. Palliative care is care that helps with symptoms of incurable disease, that's true, but only about 60% answered that correctly. This is also a true statement. The percentage of people who survive CPR when their heart or breathing stops in a hospital is less than 25%. 80% got that one wrong, which I'm not as casting aspersions. I think 80% of regular people would get that one wrong because their perception is different than what we see in a hospital. And things like addiction. So cancer patients very rarely become addicted to pain medications. Like the people who get addicted to pain medications, and I know we have a huge opioid crisis, they tend not to be cancer patients who are dealing with a lot of pain. So if people think, hey, there's a risk of addiction, maybe there would be a discouragement of being adequately treated for your pain. So a lot of this is, what do you do with well-intentioned parish clergy who didn't happen to go to medical school and are being brought into this discussion about medical decision-making? And that's a challenging place to be. They also found, as they spoke in this study with parish clergy, they found a really interesting approach. So in addition to the informational piece, the knowledge piece, they found, and this is a quote from them, the clergy were ambivalent about and adopted a passive approach to counseling congregants about decision-making despite having defined beliefs regarding end-of-life care. Beliefs about free will lead clergy to refrain from influencing end-of-life medical decisions, to value patient discretion over moral consideration. They embrace the role of supporting, not questioning, a seriously ill patient's decision to pursue aggressive or comfort-focused care. Now, I don't mean to say that that's the case with all of you folks here. Like, this is a study that was done in Boston, could be different for each individual person. But what they found was a trend, which was kind of a respect and support for, well, if that's what you want, then I will support you, which is not a bad approach to take in terms of helping other people. At the same time, if people are making decisions based on a perception of what they are called to do from a religious or faithful angle, then it would seem like clergy are in a position to engage them in discussion rather than say, well, if that's what you want, I've got your back. To say, I wonder if that's actually what you are called to do. I wonder if that's actually what God expects of you. Might be an interesting avenue of discussion. So let's look at these again. So we have divine sovereignty, miracles, sacredness of life, and suffering as God's test, all kind of pushing people maybe towards getting more aggressive treatment from a religious angle. And let's look at different ways of addressing these. So divine sovereignty, to say it's up to God. I'm not going to make any decisions actively because I'm in God's hands. Is it possible that actually accepting all this aggressive care isn't so much about divine sovereignty, it's about me keeping control of my life, which is actually the exact opposite of divine sovereignty. Because it is interesting, if we say that it's all up to God, but yes, I want that human intervention, I want that technological treatment, then I'm not sure where God is in all that, because if we truly believe in divine sovereignty, then God can do whatever God wishes to do despite what I happen to be doing as a physician. Miracles. I'm going to hold on because I'm praying for a cure and I hope that God will perform a miracle. There's an old saying, God answers every prayer, but sometimes that answer is no, right? So to say that I'm holding on because of this hope for a miracle, maybe a miracle is not in God's plan for me. The sacredness of life. So Jesus died on the cross, but he also healed a lot of people. So when we talk about suffering, which we're going to talk about in a sec, so there is suffering involved in the life of Christ, but he also healed a lot of people of their suffering, and he said, my yoke is easy and my burden is light. So to say that I have to go through suffering may not actually be what God is hoping for at this point. And then lastly, is it possible that life support isn't making God's will possible? It isn't going along with the sacredness of life that we have to hold on to so tightly, but it's actually preventing God from bringing his child home. Which brings me to a story. So you guys may know the old joke about there was a person who was in a shipwreck, and he's like treading water. And he prays to God, and he says, God, please save me. I don't want to die. And then a helicopter comes by and lowers a basket, like, you want to get in? He's like, no, I'm waiting for God to save me. And the helicopter keeps going. And then there's a ship that comes by and says, we'll give you a lift. He's like, no, it's fine. I'm waiting for God to save me. And the ship goes on, and then the guy drowns. And then he goes to heaven, stands before God, and God says, welcome. And he's like, God, what's the deal? I prayed for you to save me, and, why didn't you? And God replied, well, who do you think sent the helicopter and the ship? And then he's like, oh, good point. I wonder if there's a parallel here. I wonder if you have a person saying, who might be terminally ill, who might be suffering, and says to God, I just want to go home. I want you to bring me home. I'm done with this because this is too much for me, and I've done what I was meant to do in life. I've served you. I've followed you. Now it's time to move on. I wish you would take me home. While that patient is in the hospital getting dialysis because his kidneys are not working, on a breathing machine when his lungs aren't working. And then finally, despite all those medical interventions, he dies. And he goes to heaven. He's like, God, why didn't you bring me home? And God might say, why'd you take the dialysis? Why'd you take the ventilator? I kept trying to bring you home, and every time I did, you said yes to something that the doctors wanted to do to keep you there. I think there might be a parallel there. And I don't mean to say that Christians shouldn't accept medical care, or that we shouldn't accept aggressive medical care, or we shouldn't take a chance at prolonging life because life is a sacred gift from God. All that's true. At the same time, I don't think that our faith requires us to say yes to everything. I don't think that it is unfaithful for us at some point in our lives to say that the burdens of this treatment are greater than the benefits for me, and that I'm going to truly trust in the sovereignty of God and put my life in God's hands as opposed to accepting all these treatments that these doctors are offering me, or even asking them to give them to me. All right, so a few thoughts, which hopefully will prompt discussion. So what can pastors do, in my opinion? One is we can encourage patients to engage in advanced care planning. So my first question for you this morning was, has a parishioner ever come to you and said, here's an advanced care plan, an advanced directive, how do I fill it out? What does my faith call me to do? So that's a good question. You could flip it and say, are we in the churches actually encouraging people to go through this process? Like, if you think about it, we reflect a lot on mortality. We reflect on eternal destiny a lot. Are we in churches saying to parishioners, hey, you should think about this? Hey, you should fill out an advance directive so that even if I'm not giving you any guidance, at least people know what you want so that they're not left to try to figure it out when you're no longer able to make your own medical decisions. Could we frame it as stewardship and caring for people in your life? And can we actually take a step further and frame it as our Christian duty to plan ahead, to face death square in the eye and say, this is what I think God is calling me to do in that situation. Second thing is reassure, as I said before, parishioners that declining at least some forms of aggressive treatment does not necessarily reflect a lack of faith. Like, if somebody wants everything, then they have the right to want everything. That's fine. But if they're doing that because they feel obligated to, in a way that their faith doesn't actually obligate them, then that's a problem. And then seek clinical partners to provide crucial context. And that kind of comes back to the point about advance directives I was saying before, that every time I hear about a church saying we're going to have a get-together after services, after coffee hour, and we're going to have an advance directive filling out party, and we're all going to fill out advance directives, part of me is like, that is incredibly brave to take that step, because for most folks, they'd rather do anything than fill out an advance directive, right? Like root canal or advance directive, they might go root canal, because at least it's not mortality they're dealing with. So at the same time, I'm thinking, I'm impressed and awed by their bravery. There's a little part of me that's a little scared about what those documents are going to look like when they come out. If there's not somebody with medical perspective to be like, that plan doesn't make a whole lot of sense to me. So I think that it's important to have clinical partners. So I'd like to spend the last couple of minutes just kind of talking a little bit about what the tools are that are out there that may help you do this if you choose to be more proactive in your churches, or if you just want to be more prepared when parishioners come to you. So an advance directive is a document. In Oregon, there's actually a required form, which is a really bad form because it's hard to read and it's not super user-friendly. But basically, it does two things. It allows you to have a treatment directive, meaning these are the whats, like what treatments I want and don't want. That was that feeding tube aggressive treatment thing that we saw before. In various contexts, like if I'm dying, if I have extreme suffering, et cetera, et cetera. The second thing is the proxy directive, and what that means is if I can't make decisions for myself, then this is the person I want to make decisions for me. So let's just talk about that for just a quick second. The proxy piece is actually the most important piece. And the analogy I often bring up is the whole, if you hear the classic story of, you're walking down the beach, you find a bottle, you open it up, a genie pops out, and you get 3 wishes. What's always your third wish? More wishes, exactly, right? So if you think about it, the treatment directive answers a couple of questions, but if there's a question the person didn't think to answer, they're not around to answer it by the time you need that. If they name someone to make decisions for them, then in a sense you know who to ask the questions of, and you can ask more questions. So someone may come to you and say, what should I do about advanced care planning? And my response is always, the first thing you should do is, who do you want to make decisions for you? And there are 2 caveats in that. Number 1 is, the most obvious person may not be the best choice. And the most obvious person is, most people will say, my spouse. So what's wrong with having your spouse as your decision maker? They want you to stay, right? Like, I'm not saying it's wrong. My wife is my decision maker, but I had to have a hard conversation with her to say, like, if it comes to that, you got to do what's right by me, right? And at the same time, I recognize that is a burden. Like, naming someone as your decision maker is not a compliment. It is a responsibility. You're sort of saying, are you able to do some really hard things, even if it means letting me go? So that's the first thing. The second thing is, it's not enough to name someone as your decision maker. You got to have a conversation, right? Because you can't say, well, they know me. They would know what I want. Well, that's just not true, right? Like, how many times have you think about someone you're super close to, your spouse, your kid, or your sibling, and they do something that you're like, I can't believe they did that. I can't believe they think that. Like, we surprise each other all the time. So we need to sit down and talk to our decision maker and say, this is what makes life worth living for me. This is how much I'm willing to go through in order to have that. This is what my faith calls me to do in terms of my own health care. So if somebody were to come and say to you, Pastor, what should I do in this? And my suggestion would be to say, the first thing you should do is figure out who you want to make decisions for you, and then sit down and have a big old conversation and update them on what that is, and then continue to update them over time. Because you can't say, well, 20 years ago I had that conversation with my spouse. Well, things change over 20 years. Health changes. Obligations change. Quality of life changes. So we need to make sure we keep those conversations up. If they want to go beyond that, beyond the decision maker piece, then there are a couple of great tools out there. So one is called 5 Wishes. That's the website, 5wishes.org. And basically, it's a way of guiding folks through this. And it says the way to figure out what is important to you from a healthcare perspective is to answer these 5 questions. Really good questions, and has worksheets and all that. And as you can see, the first one is, who do you want to make decisions for you? So sometimes when people say, I want to fill out an advance directive, but I don't know how to do that. And I said, well, here are some questions. Here's a worksheet that you can use in order to try to figure out what's important to you and what's not. The other thing that I often tell people about is a great website called prepareforyourcare.org. And what that is, and it's both in English and Spanish, it's a website that has very specific medical decisions in addition to sort of overall advanced care planning stuff. And things like, do I want to go on dialysis? Do I want a feeding tube? And what it does is it actually gives you a chance to hit a little button and say, I don't know what that is. Can you tell me more? And you'll have videos of what that looks like. And it'll have real patient testimonials to say, I went through that. That's what I felt like when I went through that and how that worked out for me. So if you don't have a medical buddy that you can call up and be like, hey, what's up with that? This is a great way to look at it yourself or equip your parishioners with that. The last thing just to note, which is a medical order, but so people are just familiar with it, is this thing called Portable Orders for Life-Sustaining Treatment, or people refer to it as POLST. This is what a POLST form in Oregon looks like. Basically, a way of looking at this is it's sort of an out-of-hospital DNR form. So DNR means do not resuscitate, means we're not going to do CPR if the patient's heart stops. In the hospital, you write an order and everybody knows it. If you leave the hospital, then no one's really going to know that unless you document it somehow. So a couple of things to say about this. When you're talking to a parishioner or a family member or yourself, and you say to yourself, I'm making hard decisions, I'm wondering about what to do, and I could imagine a situation when I wouldn't want something, then you need to fill out an advance directive. What I often say to people is, if the word if comes out in that sentence, you need an advance directive. Like, if I'm in this condition, then, if this were to happen to me, then you should fill out an advance directive. If the word if doesn't come up in the sentence, if you're like, I never want that, ever, can't imagine a situation when I would want to go through that, then you need a POLST form too, because the POLST form actually tells people don't do that. And when I say people, I mean especially like paramedics. So if you have a parishioner who says, I never want to get CPR, I've decided, take somebody who's got a really bad heart and lots of other problems medically, and the probability of them surviving CPR out of hospital, like out of hospital CPR survival is 5% or less. So they're like, I don't want to go through that. And they fill out an advance directive, and they do everything they should. They put it on their fridge or whatever, they have it visible, and the paramedics show up because their heart stops. The paramedics aren't even going to look at it. Won't even look at it. Nor should they, because paramedics are not equipped to parse an advance directive that's multiple pages long that they have to kind of figure out if this, then that. Like that, you can't, if someone's lying on the ground and their heart's not working, you're not going to be like, oh, let me look through this and try to figure out what to do. Like, you got to act. A POLST form will say, don't do this, if that's really what the patient doesn't want. And a POLST form is not something patients fill out. That's a doctor's order. So I don't mean you're not going to go out and fill it out on your own. You're going to need to talk to your doctor about it. It's a big deal, but it does have the potential to spare people getting things that they really didn't want. So I just wanted you to be aware of that form and what it means and its distinction from an advance directive. All right, I think I've used up my time. So thank you all very much for listening to me blather on. Looking forward to hearing what other folks think about this and taking questions. So thank you all very much.
Thank you, Dr. Macauley. And now we're going to have our panelists come up. Thank you very much. And then I'll introduce them. Yes. Yeah.
Slide down. Thanks.
So again, many thanks, Dr. Macauley, for that very insightful talk. And now just a few words about our panelists. Pastor Tom Shive is the second from the left. He's the senior pastor or lead pastor at Gateway Church, Portland, Oregon. Pastor Jim Sequeira, Cascade View Covenant Church, Vancouver, Washington. Both serve as advisors at New Wine, New Wineskins, but don't hold that against them. Dr. Kristen White, the director of the Master of Arts in Counseling at Multnomah University. And also attorney Justin Curtis, who is an attorney at Landerholm Estate Planning, and also a graduate of Multnomah University. So really grateful for our panelists. They're going to share for about 5 minutes each, and I'm asking the two pastors to start first, Pastor Shive, then Pastor Sequeira, and then Dr. White, and then Mr. Curtis. And then we'll take questions, and so if you're filling out those pieces of paper, Ms. Mannon, Sarah Mannon and I will be picking those up, so thank you.
Yeah, I really thank Dr. Macauley for sharing this. The fastest growing age group right now is 55 and up, believe it or not. And so these questions are going to be more and more coming to clergy, and I really appreciate that. I know at Gateway we have, an elderly population, and a number of people are going through situations like this. So as I heard Dr. Macauley, I was thinking, man, there's some things I wrote down here about what I do, and I thought maybe I shouldn't do these anymore. Actually, but he came back around to encourage me. I was about ready to have an end-of-life experience myself, but I see my role particularly in three ways. One is from the side of a shepherd and a pastor, is to be with them as they walk through the valley of the shadow of death. Just to be with them and to know that they're loved and cared, and to somehow represent Jesus to them as they walk through this. I know that's not always, possible, but try to be there. And then being there in these very tender and traumatic moments when they have to make decisions. Several years ago, I had to stand with a family, and we had to make a decision together along with the doctor as to whether or not to end the person's life. The person was on life support, and we went through various discussions, and we had to ultimately end, or at least pull the plug on all the medical device, and then go walk through that given moment. And then to be a resource for people, and I think I appreciate this is one area where I was encouraged, was being a resource for them in the discussion of theology and the ethics of their decision, and to try to help them come to grip with what do they mean? What does this mean to God? What does it mean to you? Where are you at? I just want to point out as far as resources are concerned, and I'll just, because I'm a resource guy and I need all the help I can get in situations like this. I'm sure you do too. This is a recent book, 2019, that came out called Between Life and Death. And it's a gospel-centered guide to end-of-life medical decisions. And it's by Catherine Butler. And she is a medical doctor. She was a trauma and critical care surgeon at the Massachusetts General Hospital and ended up at Harvard Medical School on staff. She puts her own advanced directive in here, which is really nice. And she shows and goes through all the various aspects of end-of-life care, from dialysis to everything, and explains it. But her own particular directive, boy, when I heard Dr. Macauley, I thought, she must have heard you, because because she does exactly what you were saying. She talks about the postal, the piece of paper. She talks about her own desire, and her key thing is if she can't carry on meaningful conversation and meaningful issues in life, that she wants to end her life in certain ways. And she talks about physician-assisted suicide and a number of those things too. And it's just an excellent small guide. So I point this out to you just to share with you that it takes what Dr. Bob said and really kind of puts it in a nice form for you to think about. So I'm always a resource guy. I always need help. So books like this are very helpful to me too.
Aloha. Thank you, Reverend Dr. Bob, any other title I need to give you, but thank you very much for the resources. A week after my worship pastor's 50th birthday, a week before we brought him on staff, he had a heart attack. It was complicated with diabetes, and so he was in the hospital for 3 months. Several months later, he had to have his foot removed. A year later, he had to have his leg removed below the knee. He went back to the hospital and he just started to spiral down to where they gave him weeks to a couple months to live. And so we started going through this process of the directive. The first week he was in the hospital, we had the funeral home come, and they were talking whether to cremate or casket. We were planning his worship, celebration of life service during those 2 weeks. And then also the process of just what we heard from the doctor here. So we're going through that process. It was one of those miracle things. He had the directives and all those things filled out, and he returned to church. He had a do not resuscitate directive, and so as a worship team, we got together to talk about what does that mean? What are we responsible for if something were to happen? This past year, Park was leading worship. We were done with that part of worship. I got down to give an announcement, and all of a sudden, I just heard just this loud bang on the keys. I looked off to the side, and Park's head is resting on the keyboard. I look over. He's on the same floor as I am because we brought the keyboard down. And I'm just like, I didn't know what to say. I'm like, Park. And at first, I kind of look at our congregation, and people are just like, and then kind of the people in the front section of the church started giggling and snickering. And all of a sudden, Park says, "Oh, what? What's up?" He had dropped something on the floor. And he had reached down and banged his head on the keyboards, and I thought he was gone. And I want to look at him, I'm like, dude, don't ever do that again. I guess part of it, and I guess some of the things that I've learned from Park, when you talk about making decisions on life, I have found out it's not a one-time discussion. It's an ongoing discussion. There's this, it's not like we can say, hey, let's talk about this, but it's an ongoing discussion. Being an indigenous person, being Native Hawaiian, and also kind of running with the Native Americans and being part of that culture, when we make decisions, it's communal. They're communal decisions. There's many people that are involved in those decisions. And so I think, one of the important pieces is the relational piece, building a trust among those people that are having to make these kind of decisions and filling it out. I find my responsibility is understanding and clarity. Sometimes it's really hard just to make the decision. And I was thinking about, and I don't think I've ever made a decision for somebody, but what I find my role is making sure that the families, because it is a traumatic time, it is a difficult time to understand, when my families are sitting down with medical people, because I think you said sometimes it's hard to have even family members fulfill those things. But even when you're sitting during that traumatic time, it's really hard for families to hear it clearly, asking the right questions. So I find my role and responsibility, at least during filling those out, is helping to find understanding and clarity. Another piece for me is that, you talked about clergy overestimating things. And the hard part, too, and I wrote this as a question, was sometimes the doctors undergive information. I guess it's to protect themselves. And so I think finding relationships, and sometimes what I'll do is I'll have a conversation with the family, but I'll step outside and ask the doctor something. And maybe it's not directly, but it helps me to clarify and understand so that I can go back and better inform. But I also think it's having relationships with people in the medical field. My dad was coming to a point where they were going to take him off dialysis, so I called my best friend who's an anesthesiologist, and I said, Steve, what's going to happen to my dad? And as I heard what was going to unfold and happen to my dad, that terrified me. But my relationship with Steve is he saw my dad as his dad. So I said, Steve, what would you do? And he said, you know what, I would not continue, what needs to be done. And so having those relationships, I think, it's hard for doctors just to say, this is what you should do, because then people come back but I think having those relationships with doctors, I think, is so important with the medical field. So I think it's kind of this communal relationship. I think for me also is understanding what the patient wants. what their directive is, because I think the family also pressures them. You're not done here. We need you. We need you to stick around. And that gives, I think, the patient sometimes that idea of feeling like, I guess my job's not done here. When my dad was getting close to passing, I said, Dad, your job's done. Mom's in a memory care center. Look, and I kind of just pointed out, look at this, what you've done here, here, and here. And I've talked to other people where I'm sitting with them and saying, your work is done here. You've done this, this, and this. And so I think it's just that relational and also protecting, I think, what the patient wants, because I think the patient sometimes fears that they're letting down their family. And so I think helping the family understand again, it's getting that clarity. And it's, like in the Hawaiian culture, I say it's easier to impose than to understand. So helping people understand what the situation really is instead of imposing their love and their care and all those good things is important, is important. The other thing too, I think, I love the spirituality piece. For Hawaiians, there's kind of not really this differentiation. Every life is just spiritual. And so for us in our culture, my ancestors, my kupunas, my elders taught me, we are the descendants of our ancestors and the ancestors of our descendants. Which means that, although we might not be here physically, we're still here. The lessons that have spoken into our lives continue on. And I think from the spirituality piece too, speaking as an indigenous person, being affected by the colonizers coming to the Hawaiian Islands, thinking that God wasn't there until they got there. God is working in these people's lives longer than we have been there. We don't need to be there to close a deal. We don't need to be there to make sure that they get everything right with God. God's been working in their heart. And maybe God's saying, you know what? I want you to come home. And we need to honor that.
I'm going to stand if that's okay, A, because that's a teacher in me. Do you mind if I scoot out, Bob? But also because it's really cold and I'm right under the air conditioner up here, right? Thank you. So I'm going to stand. I love everything that you guys have shared, and I just want to kind of springboard off of that with 5 lessons that we teach our counselors that I think might be useful to you guys in this, if that's all right. So the first lesson that I would give you that I think could be helpful in this is to be brave, right? You're not going to create these issues by talking about them. And sometimes we think that. For counseling students, they might be afraid to ask somebody, have you ever thought about hurting yourself? Because they're what if now they think about it, right? We don't create these things by talking about them. We're all going to die. People have to face these things. So be brave. Whether it's waiting till people approach you or being proactive as a church, you're not going to create something that's not already there. You're just making space to talk about what's really there, and that's a gift to people. The second lesson, know what you're bringing in. Know what you're bringing into these conversations. We can't see other people clearly if we don't know what our values are, if we don't know what our fears are. So think about what do you even right now as you were driving here this morning, as Bob was talking, what comes up for you? Is this exciting? Is this terrifying? Is this, wait, we're not supposed to talk about this stuff, right? There's no right or wrong answer, but you can't see other people clearly and hear them clearly unless you know what you're bringing in. So take some time, if you're not clear on that, to think about it, to bring it to the Lord, to talk to others so that you're able to really make space for other people by knowing what's yours and making space for what's theirs. The third thing, this is hopefully relieving. Your job is not to have all the answers. Right? And our counselors think this. They have to come in with the best advice and all the answers. That's not your job. It's not your job. Your job is to start good conversations or be present in good conversations, and you will undoubtedly have wisdom in that, theologically or in other areas, but you don't have to have all the answers. Hopefully you can just be present to have really good conversations. And help other people come to their answers, which isn't about relativism, but respecting their free will. And I have some other thoughts on what you said about that. But I'm going to say those for the fourth lesson, which is as you're just being present and not having to have all the answers, don't underestimate the power of just listening and asking good questions. that is, sometimes that feels like we're not doing enough, but just listening actively and asking good questions is immensely powerful. When our students come into the counseling program, we tell them, all those tools you want to learn, we're not going to teach you any of that until like the second year. Because we just want to make sure you can really actively listen and be present and hear the other person and make them feel cared for and take them deeper places just by listening. So two quick pieces on that. I think I'm doing okay on time. As you're listening, listen actively. So listening isn't just about being quiet. That's a good place to start, right? And even James tells us, be quick to listen and slow to speak. But listen actively, not use your nonverbals, nod your head, lean in, feel free to use encouragers, show the other person you're with them and you're tracking. And you can also listen actively by reflecting what you're hearing. You can reflect the content. It sounds like you're saying, you really don't want to do this. Or the feeling. It sounds like you're really scared of this. Is that right? And if you're not right, they'll correct you. But that's okay. So listen actively with your body, with your head, with your words to reflect what you're hearing about we tell our students content, affect, and meaning. So listen for those three things and reflect them. And again, you don't have to have it perfectly. Even if you get it wrong, it helps them to clarify what they're thinking. You don't have to have all the answer. The tool is your presence. And so feel free to be brave in that too. On the asking good questions part, two thoughts on that. One is know the difference between open and closed-ended questions. Closed-ended questions are something that just really requires a yes or no answer. Do you want to talk about an advance directive? Yes or no? Those are useful if we're trying to gather specific information, but a lot of times what you're going to want is open-ended questions, which leave space for more. How do you feel about talking about an advance directive? Right? What are your concerns or what are your desires about this? So train yourself to use open-ended questions and use them not just to collect information that you're curious about, but to help the other person think about what's important to them. And this kind of goes back to what Bob said of sometimes we're afraid to offer things because we want to just let people have space to make their own decisions. But this isn't a black and white issue, right? It's not either we give them the answer or we just listen and do nothing. There is actually an in-between where we can ask good questions in a way that still lets them come up with their own answers, but brings in wisdom, right? So I think you had the question, Bob, of is it possible that life support is preventing his plan for your life, preventing you from going home? That's not imposing your value, right? You should do this, and here's why, theologically. But it's not just being silent either. There is this middle ground of asking good questions. And I think theologically, sometimes that's even a great way in these really difficult conversations to bring in theology. Have you thought about this aspect of theology? When I bring in scripture with clients when that's appropriate, sometimes it's not, hey, this is the answer, but have you thought about that Jesus wept? What do you do with that? Right? And it's just opening space for people to think about it. You can bring in wisdom, but in a way that still allows them to kind of wrestle with it. Okay, my last one. Fifth lesson from counseling is use your resources. And Bob said this as well, right? Use your resources. He mentioned medical professionals, which I think is great. Maybe counselors can be helpful, but also each other and other people in your churches, websites. I did find a great website also called Death Over Dinner. Sounds exciting, right? Death Over Dinner, though, if you Google it, and it allows you to actually put in your intentions for the conversation. So even if you're like, okay, I want to do some of this at my church, but we're not quite ready for advanced directives yet, we need to back up the train and start a little bit over here, you can put in this could be a small group thing. I'm sure people would be thrilled, but you could put in what are the intentions for the conversation, and it will give you reading materials and videos and things so that then people can come together and have hard conversations about these topics. So use your resources as well. Okay, thank you guys. Thank you for letting me warm up too. All right.
Thank you, Dr. Macauley, for your presentation. It was great, and for these comments, really helpful. I first wanted to just say, to Dr. Macaulay's point on, being a good steward, really sitting down and thinking through these issues and filling out an advance directive is an act of love for the people around you. You know, it's taking the time to consider what you hope and want in your end of life. And so taking the time to talk with them about it and kind of to your point also, you know, write it down too. You know, it's one of those things where particularly when you have kids, multiple children, and you're talking with one of them, if you write it down, then they know that they can rely on that statement that you made, and their siblings aren't going to say one thing or another and change, you know, what your words were. So writing it down, making sure that your intentions and what you want is clear is important. And then to your point, with regards to appointing a personal or a representative, a healthcare representative, it's such an important decision, and you know it's so important that the state has provided a default if you don't decide. You know, so if you don't write it down, the laws apply, and the first person who serves is your guardian if that's been appointed, then your spouse, then adult children, then your parents, and so on and so forth. And so this decision has been made for you, and you want to make sure that it's not the law that's applying here, it's what you really want. Maybe your decision does reflect what the default is already, but a lot of times it doesn't. And when you are considering this position of who's going to be representative, you're looking at not only who's going to make that final decision, but also who's going to be your advocate. Who's going to be taking you to the doctors? Who's going to be asking those good questions? And it may be your spouse, it may be a child or a friend, in terms of who's really going to be there for you in all these decisions. Who's going to be receiving your medical information? And so talking through that, thinking through that, and making sure that you have that put in place now instead of waiting until it's too late is so important. We will often sit down with clients to go through, some of these decisions, and I do often recommend to clients to talk to their doctor, not only about the pulse form, but also, their advance directive in terms of what they want for their final decision. It's so personal, it's, and I love the framework that Dr. Macauley provided today in terms of how our faith really does change or apply to the analysis. Another legal tidbit is when you appoint someone in the advance directive, in order for them to legally serve, they have to accept it. And so they have to sign and say that they accept that position. And so you want to just make sure that you're complying with the laws, and the doctors or your attorney or counselor, whoever you're going through, you're filling it out correctly. I think of that, the after church service and putting it together. Did they even fill it out correctly, right? And is it a legally binding document? And so the representative has to accept it here in Oregon. In Washington, you actually don't. The representative doesn't have to accept it. So you can name whoever, and they have to do it whether they want to or not.
My neighbor Rob.
Yeah, your neighbor. Yeah, just choose whoever. No, but I mean, even in that circumstance, we almost always recommend that the client.
Just a quick question.
Yeah.
Have to repeat it for
In
the
the state of Oregon, if you don't fill out the official form, what's essential on a piece of paper to make it valid?
So to make it valid filling out the advance directive requires 2 witnesses, your signature, or your signature and a notary. And so that's on the advance directive. To make a will valid, you have to, there's a lot more requirements, but for an advance directive type of intent statement, I don't know if there's a legally enforceable. If you comply with the statute and have the language provided in the statute on your document that you're signing, and you have a notary or 2 witnesses, it should be valid. But when it comes down to it, the doctor's going to, and you could talk to about this too, Dr. Macauley, in terms of, what was the intent, and looking at the document, trying to find someone who they, appointed and what they wanted in terms of in life decisions. And so, again, thank you for having me here, and the comments have been great today.
Thank you so much, panelists. And Sarah Mannon is taking your questions. She'll bring them to me. And the first question, I have one here. And we're just going to, for the sake of time and to get as many questions out there, if one person could respond to each of the questions rather than several people respond. So while clergy might overestimate capacity for care, my experience is that doctors, medical professionals are hesitant or unwilling to advise capacity for care. Where, in that case, are clergy or family to go? Anyone on the panel, including Dr. Macauley, want to respond to that? If that's the case, and when that's the case, where are clergy or family to go?
Well, I can sort of
Oh, the mic, please.
I got this.
Oh, that's right.
So from a physician point of view, I think that that's often true. I think some physicians sort of say, here are the facts, let me know what you want to do. I personally think that's an abdication of professional responsibility. And so ideally what physicians should do is they should make a recommendation based on the established goals that the patient has. So it's not what the physician says, I think this is the right thing to do. It should be, I've heard you, I've heard what's important to you. Based on that, this is my medical recommendation. Like an analogy I often uses, patients are the captains of the ship and the physician should be the navigator. So the patient says, I want to go there, and the physician says, well, if you want to go there, the best way to get there is to go that way. So what I would say is that's a terrible place to be when you don't feel like you have people who are helping you. Physicians aren't going to tell you what to do, or they shouldn't, but what they should do is say, I understand what your goals are. This is going to help you achieve them. I understand what you're afraid of. This is going to help you avoid that. And so what I would do is I would sort of invite physicians into that conversation to say, no, I need more from you. It's not enough just to say, here are the facts. I'm going to tell you what's important to me. I'm going to tell you this is my loved one's advance directive. This is what's important to him. If this is what he or she wants, how can you help us understand the best medical way to get there? So I would sort of push back a little bit on that.
Thank you. How do you handle the dilemma of healthcare professionals who quote unquote push interventions that the patient or loved one did not indicate they wanted in their prior planning for end-of-life care? Again, one of those here in the Q&A time.
That feels like a medical question too, so I'll take it on. And that does happen. Like, anyone who's been in the medical system, one thing leads to another, and there's a momentum. And one of the reasons there's a momentum is that the default is we do everything for everybody unless someone says stop. And so sometimes that's because no one said stop. And so I think, again, we need to empower patients or speak on their behalf and say, not necessarily stop, but hold on a minute. Does that make sense? Just because we did that last week doesn't mean we should do it this week. Just because we did that doesn't mean we should do more. So I think that recognizing that there is this momentum build that happens in modern medicine, but patients have the right and they should have the voice, and they may need other people to voice it for them to say, wait a second, does this really make sense for what their goals are?
5 Wishes is a great resource, but it's not accepted in Oregon. What are the steps we need to take to make this a legal document? I think we know who that's for.
So I've actually heard that the 5 Wishes, I haven't looked specifically at the 5 Wishes to see if it is legal in Oregon. I've heard it is accepted in all 50 states, actually. And so, confirming on that would be important first step to take. I recommend to clients to use, the state form or, the form provided by the state legislature. That guarantees that you're going to, follow the laws. Kaiser has their own kind of 5 Wishes Health Advance Directive form that they fill out with their clients. And we always advise clients to go through that with their doctor. And, I haven't personally seen it, but it follows the laws of each state. Another aspect to it is, each state has different laws with regard to this and different language. The Oregon Advance Directive sounds much different. The language of it sounds much different than the Washington healthcare directive. And so each state is different, so making sure that your directive that you're filling out online or whatever you're doing with an attorney or doctor is complying with the state law.
Thank you. Now, this may be for Pastor Jim, but end-of-life decisions from a family perspective seems to be centered around quote-unquote blame and quote-unquote responsibility. After the life has ended and the decisions have been made, how do clergy address this concerns with parishioners or in their parishioner context? It had mentioned for the Pastor Hawaiian, but perhaps both of you want to speak as pastors.
Repeat that question again, Paul.
End-of-life decisions from a family perspective seems to be centered around quote-unquote blame and quote-unquote responsibility. After the life is ended and decisions have been made, how do clergy address this concern with their parishioners?
Well, a lot of these things come because of grief. And people are going through grief, and it's a natural sort of way of handling this end-of-life decision. And I usually try to help them understand grief and what grief's like, and the anger that they're going to experience, and the blame that often goes along with grief. And we talk about that, and to try to tell them some of the things that are going on here are natural, and you need to kind of work these things out, but make no judgment on them. Just to say, you're going to go through cycles where there's always going to be blame, and there's always that kind of thing, and you need to walk through that valley of the shadow of death with them, and help them in their grief, and really understand the process of grief, and just let them and encourage them with your tender care and your comfort and your counseling ear, as Kristen said here. I think that's important.
Great, thank you, and thank you, Tom. Jim?
Yeah, and I would add, in addition to grief, I think when people blame, they're trying to deal with something within themselves. And so maybe something that wasn't fulfilled, maybe they feel like, I wish I would have. And so I think walking through them and just trying to get out maybe the frustration of something that went unfinished, and those kind of hurts. And so for me, it's when you kind of see that blame, it's within the soul, the rest, something's going on in addition to grief.
Thank you. Our parishioners may not be cognizant of their, and I underline here because it's underlined, their mental health challenges such as depression. Mental health, especially depression, impacts end-of-life decisions. What suggestions might you have for how to assist elderly parishioners to get help with mental health care needs? And it could be not just elderly, but maybe others as well. So, Chris?
Obviously you can suggest that. Again, you can be brave and talk about it. But I think also reducing stigma about mental health and about depression, about therapy, talking about those things openly, just like you're talking about death and dying and advanced directives, to be able to say depression is normal, going to therapy is normal, you don't have to be sick to go to therapy. I think talking about those conversations can be immensely helpful, whether it's from the pulpit or one-on-one with somebody. And there's a lot of wisdom also in this question of, we don't want people to be making decisions for an advanced directive or anything else out of despair. And so if you see something like that, to be able to talk with them, and it seems like this is not a hopeful place, and what's happening here, and how can we bring other people into this conversation that might be able to be helpful to us as well.
Thank you, and this one is for Bob. So is there any literature or studies that show any correlation between a parishioner's perception of salvation and the degree of aggressive or conservative care at the end of life?
I'm not aware of anything specific to one's concept of salvation. I do think that the religious coping scale touches on one's relationship with God and one's eternal destiny to some degree. But I think that I don't know of anything that is specific to one's sense of salvation or heaven specifically on that point.
Well, those are those are the only questions I have. So I want to offer opportunity for others of you to reflect on either the questions or things that stood out to you further based on one another's remarks. So,
I have a
Jim?
question for Dr. Bob.
Yeah.
Thank you very much.
Yeah.
At least my experience
Uh-huh.
with dealing with these things, it's responsive or reactive. How proactive can we be? I mean, especially because normally we think about, oh, this is stuff when you get old.
Mhm.
But I mean, how proactive do you see that we can be with regards to initiating these things? Or can we be proactive, or is it strictly a reactive? Like, we're at that place now, we better start doing something about it?
Yeah, that's a great question. So one thing I often say to the medical students I teach, who are typically they're in their 20s, and so a lot of the stuff we're talking about, it's easy to say, well, I'll get to that one day, although many people don't. The three most contentious, from a legal perspective, the three most contentious legal cases in this area over the last 40 years about whether or not to provide life-prolonging treatment in the context of familial strife all involve people in their 20s. And I'm a big fan of doing things gradually. And we've already talked about how this is the kind of thing that doesn't happen in one moment in time, it happens over time. If we can normalize things early on, like who's your decision maker? Like that's a hard thing, you gotta deal with it, but you don't actually have to deal with the decisions, you gotta sort of talk about your values and what you hope for. If we could sort of say, hey, everybody should have that, like that's starting point number one from the point where you're young and healthy, that's the best time to do it. And then later on, when you start having some health problems, then it's sort of like, well, I could see this coming down the pike, what do I do with that? So the more we can be proactive, I love that idea, and normalize it to say, this is part of what we should be doing. Like we say, you're going to say, if you have kids, you're going to save for college if you can, right? You're going to hopefully have a will, so in case something happens, so people know what to do. And you should do this. Like if we bring it into the realm of, hey, everybody should be doing this, and especially speak to it on a spiritual level, like we've used sacred terms. We've used the term stewardship. We talked about caring for people when we are no longer physically able to care for them at that moment. When we talk about how does our faith impact this, this is not something that we do external or separate from our faith. This is part of our faith. Mm-hmm. And I think that bringing it into that environment could help being more proactive about it. I love that question.
Oh, we do have one, if I could.
Can I add one thought to that really quick?
Well, you have a mic.
I do. Okay, well, so I guess that means I can. I like that you're getting at what people are bringing into this too, and recognizing and maybe calling out to people that being proactive isn't selfish, but is a way that they can care for their families to make these situations easier. I mean, they're impossible, obviously, when we're facing these things, but it's worse if nobody knows what's supposed to happen.
Really loud.
Then we'll have to I'll repeat the question.
Okay.
Oh, wait, now you have it.
All right. I found it intriguing, Doctor, when you talked about positive religious coping versus negative religious coping. Even those terms, for a good Christian that's attends church and has been faithful, to even feel that they're being negative, they want to deny those feelings. Okay, so that if they have a doubt, like being ill, being so ill, thinking, oh, I shouldn't feel this way. So there's going to be that initial part of denying any negative feeling, and no, I'm going to be the good Christian. I'm going to put my hope in God. I'm going to do, because that's what we should do. That's what we're encouraged to do. So how do you best work with people who really have those questions, and family members of, why is God doing this to us? We've been good people. We've been faithful people. We've done all the right things. But they're afraid to ask those questions. And so getting to a meaningful place where you can talk about it without calling it, I mean, you wouldn't tell them that, well, you're having a negative experience right now. But still, that is the reality of many people. When you're well, you don't even imagine you're going to ever feel this way. But when illness comes upon you or upon someone you love, doubts flood you. And how do you get to the real conversations? Can you approach that? So I'm trying to articulate it better, and I'm not doing it as well as I want to, but You get what I'm saying?
I do, yeah. I defer to the pastors on the panel to sort of talk about how to address the negative, positive thing. The only thing I would say as preface to that is it's a scale, like it's a validated scale. They had to sort of break it up into positive and negative, and the reason that they focused on that is because the results were all the more surprising because it was positive copers. Like if it was negative copers, you could kind of understand that. And it is a bit of an arbitrary distinction because I don't think that there are the negative people and the positive people. Like, we all grapple with that at various stages of our life. But from a pastoral perspective, I'd sort of defer that question about, how do you deal with situations when people do say like, why me if I've done everything that I should do and I'm a prayerful person and this shouldn't be happening?
Well, some of it for me is constant teaching in the scriptures about suffering and those things. When you talk about those things, I mean, if I'm doing the work that the scriptures ask me to do, I'm going to talk about suffering and pain in messages prior to this, and hopefully they'll have some of those things already, in their mind. But sometimes the why questions, I'll be honest, I say that's above my pay grade. It's above I can't give an answer to that question. All I know is God is walking with you through this, and he loves you through this, and your pain is a pain to him, and your hurt is a hurt to him. And I can't answer the why question because that is above my pay grade. That's an area I cannot really address. Oh, I could say, well, James says this, and Romans says that. That's not very helpful. I find that when I say, I don't know. I'm as anxious about this maybe as you are when it comes to some of these things. But let's just know God loves you through it all. And Jesus wept and walks through your pain. That's about all I can say.
Just lastly, very quickly, then.
I would say there was a period in our time where our church was kind of like the cancer church. And so, like my brother said, you always talk about it, you always teach about it, you always talk about a world. We live in a broken and crooked world. Good things happen to bad people, bad things happen to good people. But during this cancer time, we had some people that were on the journey but realized that God wasn't punishing them, that this was part of their journey, and allowing them to have a voice, to let them speak and share and give testimony to our church, our congregation, to our family, to say, you know what, I don't know why, but I know this. God's not punishing me. God's not calling me home sooner than everybody else, but we live in a broken and crooked world. And this is a mystery to me, but God's walking with me. So allowing, I think, people that are on the journey who are willing to share their testimony is helpful in that journey.
As we close up, there were just a couple of questions that came in at the very end. And first off, can we receive a listing of all the studies mentioned in the presentation?
Yes.
Okay. Then the question is how. I suppose you could get it to Sarah and me, and then Sarah could make that available to whoever contacts her.
So there's a tiny URL like on the first couple of slides. Everything, I forget exactly what it was.
It's tinyurl.com/supporting-parishioners.
Yeah. So all the slides are there, but the specific references I can send to Sarah and Paul, so they'll have those.
Thank you. Is the post order, or are the post orders applicable to mental health emergencies? And how long does this post order last for, its expiration?
So posts don't expire. So once it's signed, it's active unless it's rescinded or altered. And for mental health emergencies, all it deals with is if your heart stops, and then this other section is if you need aggressive medical care, even if your heart is still beating. So it really is not applicable to mental health emergencies, it's only about physical emergencies.
All right, thank you. And if you had other questions, feel free to ask those here presenting this morning, and they may have opportunity for a few minutes to respond to those questions. I wanted to thank Sarah Mannon as well for all the work she's done. She offered, based on your talk, by the way, when you talked about have someone else other than your spouse to, be responsible, she immediately said, "I'll do it, Paul. I'll do it." And I think she wanted to do it today. The only problem is she's going to have to compete with Brad Harper, Associate Director of New Line, because he also wants to do it.
Christmas card my daughters gave you that one year?
That's right. So I wanted to thank Dr. Macauley and our panelists for their incredibly potent and prudent perceptions and insights. And thank you all for attending and asking great questions. It was a great forum this morning. Many thanks. Thanks, Derek. God bless you and have a wonderful life. See you on the other side.
And there's still food back here and juice, so please.